Make host. Okay. There you go. You got it. Okay. Welcome, welcome everyone. It's so lovely to see you all, or see your name. What I'll do is try and get rid of, you don't really want to see us, do you? I'll just drop it.
Well, my face, Louise, my face, it's Anne. My face has disappeared from the screen. Should it have done?
Yeah. We just want to see
that's
Melody. Yeah.
That's okay. Thank you.
Yeah. Welcome everyone. It's lovely to have you here, and to those that will watch the recording of this. I watch many health webinars, and I think this has been my absolute favorite, Melody. So that's why I've asked you to come and present again, because the message that you have to share is so important. I don't think we realize actually until we hear you speak how important it is. So very grateful for you to be here with us. So go ahead and introduce yourself and tell us all about you. And if everybody wants to mute themselves, and then we've got time for questions at the end, that'd be great. Thank you.
So, hi everyone, my name is Melody Norton-Evans. I am a clinical specialist pelvic health physiotherapist at Northampton General and also at Coventry Meriden Hospital. I've been working in pelvic health now for approximately 20 years. The vast majority of my physiotherapy career has been spent in women's health predominantly. I do treat men, but I prefer to treat women. They're much easier. So tonight, Louise asked me to talk a little bit about my job and what I do for my work. I'm very passionate about it. So I'm going to talk about pelvic floor health, and to give a lot of women have just never really been taught how their body works properly. And when we have education, I firmly believe we are much better off as women to fight for what we need to, although we shouldn't have to fight, and to be able to live a fulfilled life. All of the symptoms I will talk about today have never killed anyone, but they have removed all quality of life for a vast many of my patients that I see all the time, and people just stop living. And so that's not the point of life. So I truly believe that this is the key: education, and then get on and live the life we're supposed to. We shouldn't have to think about our bladder every day. So I'm going to go a little bit over the anatomy of the pelvic floor and the bladder, how a healthy pelvic floor and bladder work, what can go wrong, why does it go wrong, treatment tactics that we can use, and how to do pelvic floor exercises, and where, if you feel, having listened to me, that you need a bit more help or you need some professional guidance, then where you can access that. I'm more than happy for people to ask questions, pop them in the chat if it's something you don't want to, you think you'll forget till later. I'm happy to, mold this presentation to whatever's needed. So this is a picture of as if your body's been cut in half down through the nose. And we can see, hopefully this is an image you have been used to seeing. I don't know, I hope you can see my mouse moving on the screen. So here at the front we have the pubic bone. At the back we have the spine coming down into the sacrum and the coccyx. And then moving from the front we have the bladder with the urethra to the outside world. The uterus, which sits right on top of the bladder, which is when we're expecting a baby, especially in the first few months and the last few months, we feel like we need to go to the toilet all the time because there's actually a baby sat on it. And then the bowel at the back, and it's all incredibly close for women. If something goes wrong in one area, it's going to have an effect on the other areas. So this is the anatomy of the pelvic floor. Now, the pelvic floor is a group of muscles. It has a really important function in lots of different areas, but it's a muscle that is highly neglected. You can't exercise one part of the pelvic floor without exercising all of it. So I couldn't ask you, to contract one muscle on the right hand side and you not contract the left. It's designed to work together. It sits as the bottom of your kind of core musculature, which your diaphragm sits at the top. You have 3 layers of abdominal muscle that wrap around your body like a corset, attaching to the bottom of the ribs and the top of the pelvis. And then your pelvic floor sits at the bottom. And within that pelvic cavity and within that abdominal cavity, the vast majority of your organs are. The difficulty we have as women with the pelvic floor is that in the body, muscles go from bone to bone to ensure that they can pull properly and lift and move us. Only in the perineum and in the pelvic floor, if you put a bone in the middle of it, you won't be able to deliver a baby. So it relies on fascial strength and muscle tissue. And that's why when we have children or we go through the menopause or there's trauma to our pelvis, then we can really struggle with our continence and pain. So how does the pelvic floor work? As I mentioned before, it has 5 key functions. Just trying to move over the screen. So it's a group of 10 muscles that work as a unit. So it helps control the bowel and the bladder. It keeps us continent of both urine and feces. Your pelvic floor has to work all day, every day, all day and all night. And the only time it relaxes is when you empty your bladder or your bowels. If it relaxed any other time, you'd be incontinent. So it's unlike any other muscle in the body. Even the heart gets to rest between beats, as does the diaphragm between a breath. So it's really important it's in tip-top condition. It gives stability to the spine and the pelvis. A lot of patients have lower back pain. We'll find that their pelvic floor isn't working properly. It supports the abdominal and the pelvic contents. There is nothing keeping your bowel, bladder or uterus off the floor other than your pelvic floor. There are no magic ligaments holding everything up from the top that are strong enough to do the job. It has a really important role in sexual function for women, and that's key. And it also has a protective reflex to protect us from bowel and bladder accidents. If we sneeze or we cough, it's designed to protect against all of that. So as I said before, it works at approximately 30% of its contracting power all of the time. Oh, I think I missed a spot. And one thing that's really important to remember is when the bladder is relaxed, the pelvic floor is contracted. And when the bladder contracts, the pelvic floor relaxes. And that's really important because often a lot of women, and historically a lot of women were told, if you just stop and start the flow of urine, then you're exercising your pelvic floor. And whilst that is completely true, you are exercising your pelvic floor, it will upset the very carefully balanced pelvic inhibitory reflex with the bladder, and it can actually make symptoms that women are experiencing a lot worse. So whilst it is a pelvic floor contraction, we don't want you to stop and start your flow of urine. It will damage the pelvic floor and the bladder's delicate balance. So how does a healthy bladder work? You have your kidneys. You've got 2 kidneys. They are high up. They're actually within the rib cage, designed to be protected by the rib cage. And they are constantly filtering urine, producing approximately 0.5 ml per kilo of body weight every hour. The urine will then flow down the ureters and it will empty into the bladder. And the bladder is made of muscle, it's called a detrusor muscle. And it's a little bit like a balloon in that when it's empty, it will shrivel down a little bit and it will slowly kind of enlarge as it gets full. And then there's a small tube of 4 centimeters from the bladder to the outside world called the urethra. Now, the bladder, so it fills slowly, and it will give you a gentle warning which can be controlled voluntarily. So as you're going about your daily life, your bladder around about half full, which is around about 200 mils in old money. That's what is that? That's about 4 fluid ounces. I do my job in mils and I cook in fluid ounces, and I don't cross over us. I get confused. So it will give you a gentle warning at about half full that you need to go, but you should be able to override that and say no. And most of this is subliminal. You're not aware of it. It will hold as 500 mils and a pint for 4 hours, and it can do that. That is the normal healthy bladder. And it should empty about 6 to 8 times a day. And when it empties, it should give you plenty of time to get to the toilet. You should be able to sit down, the pelvic floor will relax, and the bladder will squeeze and pretty much empty fully. It will always leave a little bit, usually 5 to 10 mils. We would, in a medical sense of view, we won't worry too much if it leaves up to 100 mils in the bladder, but it will usually leave something, but it should empty pretty much completely, and that should happen 4 to 8 times a day. And once at night, we deem acceptable. So if you're waking once at night for the purpose of going to the toilet, that's okay. Any more times than that, we'd consider it a problem, because really it shouldn't need to empty. There are hormones released to prevent the urine production at night time. So what can go wrong? First thing that goes wrong that most people are aware of is incontinence. And we've got very good in this world of telling women it's quite normal to have a little bit of an accident when you've had children or you get a little bit old. I would argue, as would all of my colleagues, that no, that's not normal. It's very, very common, but it's not normal. People can experience urinary continence, which is broken down into 2 parts: stress incontinence or urgency. I'll go over what all of these things mean, and they are similar symptom, but caused by very different things. So the way we treat them is very differently. Also fecal incontinence. Urinary incontinence is bad enough. Fecal incontinence will destroy women's lives. They will just stop their life living. I have patients who've never left their house other than to come and see me, you know, for 2 or 3 years. Their lives are completely dictated by their bowel. We can also get urinary frequency, where patients are just going to the toilet all the time. So we should probably go every 3 to 4 hours throughout the day. Patients will go. I had a patient the other day who came to see me. She was going every 15 minutes to the toilet. I mean, her life just lived around this toilet. I felt so desperately sorry for her. It's got into a habit of not being able to hold its full volume, so it will tell her to empty constantly. Nocturia, so that's waking up at night time to go to the toilet. And again, I'll have patients who are getting up 7, 8 times a night just to void and empty their bladder, which is just awful for them. Incomplete emptying is another problem that happens. So patients aren't fully emptying their bladder for a different reason, and then they think they've finished and they haven't. They get up, they go and do their normal activities, and then they have to go back to the toilet. And so they will be constantly worrying about leaking. They will constantly live near their toilet just in case that happens again. And the other thing that can go wrong is prolapse, a pelvic organ prolapse, which it's quite common. It's more common than people think. There is an argument that all women who have carried a baby have some degree of prolapse just because of the weight and damage to the pelvic floor. But it can make life very difficult. And most of us will probably know someone who has had surgery for prolapse. And it can decrease sexual function. And I see this a lot, particularly in younger women who have had very difficult tears and quite nasty obstetric trauma. And they will come through to see me as well. And the pelvic floor is key to solving a lot of these problems, which just has massive relationship impacts as well as self-esteem issues. So incontinence is simply the involuntary loss of urine or feces. In the UK, it's estimated that 5 million people suffer. The vast majority of those are women. 50% of women reporting incontinence were moderately or greatly bothered by it. 27% of those women were unwilling to go to places where they were unsure about the availability of toilets. My patients have an I Spy book of toilets. They could tell you the toilet, wherever the toilets are in town, which shop's got the nicest one, which shop's got the cleanest ones. Like, they'll know where the toilets are, and they won't go out unless they know where the toilets are. 31% of patients will dress differently because of the problem. I did have a patient a long time ago, and her goal was to wear white trousers because she didn't wear anything that wasn't black. She wouldn't wear jeans, she wouldn't wear anything coloured other than black because she was so anxious about her urine problem. 23% say it affected their sex life, which I just think is very difficult for everyone concerned. 23% say it reduced their activity levels. I have a lot of women who won't go to the gym, they'll stop running, they won't go swimming, they won't get on a trampoline because they're so anxious about it. And 25% of women describe feelings of frustration and or embarrassment, which I actually suspect is a lot higher. So stress incontinence. Stress incontinence is caused by weak pelvic floor muscles. And that's where my role really comes into its own. I work in a multidisciplinary team with consultants and nurse practitioners, and my role is to strengthen the pelvic floor muscles. So it's stress incontinence. It doesn't mean you're stressed. It means that any increased pressure into your tummy, into that cylinder we talked about at the beginning with the pelvic floor at the bottom, diaphragm at the top and the muscles around, any pressure increases in there and the pelvic floor muscles are too weak, and because they are the bottom and because they're working against gravity, they're too weak to close around the bladder neck and you leak urine. That can come from running, jumping, sneezing, coughing, walking, lifting, laughing. And it's a very common problem. It's quite common to hear women will experience it in the last stages of pregnancy, and I think we can all understand the stress on a pelvic floor of a 7-pound baby, or 10 pound in my case. So that's what's causing it. And so the treatment is to strengthen the pelvic floor muscles so that they can close the urethra and you don't leak. Usually in stress incontinence, women will only leak a small amount of urine, but you take a teaspoon of water and put it on a piece of fabric like your knickers, it's going to feel very wet and very uncomfortable. And you can leak urine even after you've just emptied your bladder, because we never completely empty your bladder, and and as soon as you've emptied, your kidneys start filtering again, like they keep filtering. So it's not uncommon to say, oh, well, I went to the toilet and I'm still leaking and I don't know why, so I just keep going to the toilet, which is about the worst thing you can do. So that's stress incontinence, and it's caused because there's stress on the pelvic floor and the pelvic floor is too weak to counteract that. A different type of continence issue is called, sorry, I'm just letting someone in. Oh, I stopped sharing. I didn't mean to do that. Sorry. Share. So a different type of problem is called urgency and urge incontinence. This is caused by an overactive bladder, and we don't really know why patients get an overactive bladder. There are lots of reasons patients can get them, but we may never narrow down why a particular patient got it. There's lots of causes we're unsure of yet. So urgency is a sudden, desperate need to go to the toilet and struggle to control it. And for those women who've never perhaps experienced that, if you've had a bladder infection, urgency is one of the symptoms where it's you need to go and you need to go now. That's urgency. If you don't get to the toilet in time, then we consider it urge incontinence, if you can't stop the flow of urine. So you can have patients who have urgency, but they don't have urge incontinence because they can get to the toilet on time. Ooh. So other symptoms patients can experience are frequency, that's a constant and regular desire to pass urine, and also nocturia, which is having to wait more than once a night to empty your bladder. So that's incontinence. So one of the other main symptoms that I treat is pelvic organ prolapse. A prolapse just means something is in the wrong place. And pelvic organ prolapse, or POP as we call it, occurs in around about 50% of women, but not all women are symptomatic. And one thing that's really key to understand my area of medicine is we're all about quality of life and we're all about symptoms. As I said, no one's ever died from a prolapse, but their comfort level will vanish overnight. So we very much treat on symptoms. And this is caused by weakness in the pelvic floor structure. So symptoms of a prolapse can include a bulge in the vagina, a heavy dragging feeling, lower back pain, bladder symptoms that we've just talked about, fecal incontinence symptoms, pain on intercourse, chronic constipation, tampons won't stay in place is another one that we hear. So those are symptoms. Now, prolapses are graded between 1 and 4. However, it's really important to remember that the grade the grade is more for our, as health professionals, benefit, and it's about the movement within the pelvic structure. It's not about symptoms. So I can have a patient with a grade 3 prolapse who has absolutely no symptoms and they're fine. We're not going to operate on that woman. We will do conservative treatment, but we won't operate on her. Whereas we may have a patient with grade 2 who just can't function anymore and she's in agony. She would be a patient that after all conservative treatment would more likely go through to surgery. So there's 3 things that can prolapse within the pelvis for women. First of all, the first picture on the left is no prolapse. So that's roughly where all of the organs should sit, and the little line at the bottom is roughly where the pelvic floor is. So then you can have a rectocele, which is the top right picture, and that's where the bowel pushes forward and women can feel a lump. If anyone recognizes that they can feel a lump when they wash or clean or any of those symptoms, if you can feel something, if it feels like your cheek, it will either be a rectocele or a cystocele. And that's the bladder, cyst is bladder. So that will be the bladder's tipped backwards and you'll feel a lump into the vagina. If what you're feeling feels like the tip of your nose, then what you're feeling is your cervix and your uterus has dropped down. And the thing about all of these prolapses is when one thing slips, it pushes everything along, or everything shifts slightly. So it's not uncommon to find a patient with all 3 to a varying degree. You can have a patient with a grade 3 cystocele, but there's more likely they've developed a grade 1 uterine prolapse and a grade 1 rectocele as well, but the cystocele is the primary, the first organ to drop. So what can cause these symptoms, any of these symptoms? The first and most obvious is pregnancy and childbirth. Now, I treat women all the time who have not had children, but overall, this is the biggest cause of these symptoms. It's actually the pregnancy that causes a lot of the damage. Most patients imagine it's cesarean childbirth, and so a lot of women will opt for a cesarean section thinking they've escaped. The best way to explain this to you is if you imagine holding a handbag for around about 9 months and you never ever put it down and it lived on your shoulder for 9 months, it got heavier and heavier and heavier till it weighed about 2 stone, and there aren't many of us who only put 2 stone on with a baby, and then you even have to carry it at night time. You can imagine how your shoulder would feel, and that is what your pelvic floor has done with every pregnancy. And we haven't even reached childbirth. Childbirth would be then like asking you to put the bag down and start 100 military presses with about a 15 kilo weight above your head. You can understand why your pelvic floor takes a real hit. So that is overridingly the biggest factor for these symptoms. However, a lot of the patients I treat who have pelvic organ prolapse or incontinence that have not had children are often engaged in heavy manual work. It's not uncommon to find nurses who've never had children with these problems, postal workers that have worked shifting the mail around, gardeners, women who are massive fans of gardening. It's not unusual for them because the heavy lifting, all of that pressure goes down through the pelvic floor. Smoking is has a huge impact on the pelvic floor, which a lot of people don't realize. Smoking is like a 3-pronged attack for your pelvic floor. First of all, the blood vessels within your pelvic floor are very small. These are very small muscles. This is not your biceps or your hamstrings or your quads. These are small muscles. Some of them are only a couple of inches long, and so the blood vessels that give these muscles oxygen are very small, and so smoking blocks them, and it blocks them very quickly compared to other muscles. So a reduced blood flow to the muscles means reduced oxygen. They can't produce the contraction they want to without the food source and oxygen source. The second thing for smoking is they are anti-estrogen, and estrogen is a huge part of pelvic floor health. The pelvic floor has lots and lots of estrogen receptors, and when we start reducing our estrogen, then our pelvic floor takes a hit, and smoking will do that for us long before the menopause if we're a smoker. And the other thing for smokers is they have a persistent cough. A lot of them don't think they have a persistent cough. It's just such a part of them that they don't realize it, and that's extra pressure constantly on the pelvic floor. I have treated younger patients with persistent coughs, especially cystic fibrosis. Girls in their teens will have symptoms of stress incontinence because that's how much damage a cough can create on the pelvic floor. Increased weight. So we do know increased body mass index will affect pelvic organ prolapse, and it will affect stress incontinence particularly. One quite big study was done a while ago that showed a drop in 10% of our body weight can improve symptoms by up to 90% of urinary incontinence symptoms that are caused by stress. That is quite a big difference for effectively quite a small loss. So it does have an impact. Women who suffer with chronic constipation, they really can struggle because that's like bearing down and giving birth to children all the time, and it stretches the pelvic floor and it stretches the pudendal nerve which feeds the pelvic floor. So that can be a real problem. And certainly for all of my patients, one of the things we would tackle in the first session is managing their constipation. Here we go. So repeated bladder infections. So if patients have repeated bladder infections, that can cause problems. If the bladder gets into a bad habit, the bladder thinks the way it is when it's infected is normal, and therefore it just carries on behaving that way. So that's quite a reason we see quite a bit. The fluid that we're drinking, the type and the volume of fluid that we're drinking. I spend a lot of my days telling patients not to drink caffeine and alcohol. I have to bring most of my patients off tea and coffee. They don't like me for it, and they don't believe me when I tell them I don't drink either. But caffeine has a real effect on the pelvic floor. We take caffeine to keep us awake. It keeps the bladder awake all day and all night. And the amount that we're drinking, patients will cut down on their fluid, because if you're not drinking as much, you won't go to the toilet as much, which makes sense until you bring in the concentration of urine and the effect the urine can have when it's concentrated. It will make symptoms a lot worse if you've got concentrated urine, because it will irritate the bladder and the bladder will just want to empty. Training as a child, we train girls very differently to the way we train boys to go to the toilet. For many of us, we start on a back foot, we guards our bladder. When little girls are training, we'll say to them, go to the toilet just in case, because holding them out behind a tree is not very easy. And so they will get into a habit of going to the toilet just in case. And that doesn't allow their bladder to stretch to its full volume, and it doesn't allow their bladder to learn what their full volume is. Little boys, however, we don't do that to, because we can just drag them behind a bush and they're ever so easy. So some of us are starting on a back foot, and we can undo that, but most important thing is to make sure we're not passing it on to the next generation. It drove my husband mad when our girls were born, because I refused to take them to the toilet when we went on holiday, and if it meant stopping off on the journey halfway along and holding them out over a drain, then that's what we did. But it can be quite key. Thing to remember, however, is if we're about to jump onto the motorway and we haven't been to the toilet for a couple of hours, it's probably very sensible to go. But if you've just been to the toilet in the last 15 minutes and you're nipping out to Sainsbury's or Aldi, then you do not need to go to the toilet. Your bladder can hold, unless you've drunk the Atlantic Ocean, really. So, and the other one is menopause. Now, this is a really hot topic at the moment, especially thanks to Davina McCall. The menopause has a huge impact because of the loss of urine, the loss of estrogen in our systems, and the pelvic floor is highly estrogenized, and the vagina is highly estrogenized, and as also is the urethra and the bladder. So when our estrogen drops, what estrogen is responsible for is pulling fluid into tissues. Now, we hate that, especially when we're younger, because we'll be on a diet and the skirt fit on Monday, but even after 4 days of dieting, the skirt didn't fit on Friday. And that is all down to estrogen and water retention. Now, we don't like that, but actually when we're talking about vaginal tissue and bladder tissue, we want those cells highly estrogenized and full of fluid. If you try to think of a plant without water, which isn't hard after the past 2 days we've had, and how it will wilt, and you think of a plant when it's been fully watered and it's standing tall, if you can imagine that as muscle tissue and tissue within your body, you can understand which tissue is going to give you the most support and the best contraction is going to be tissue that's highly estrogenized and got plenty of water on board. And so estrogen is crucial to making sure that this is the case. So a lot of our patients will go on to vaginal estrogen. I understand that patients have a concern about HRT. The research done 20 years ago was not good research at all. Ovestin, which is an estrogen cream that's used in the vagina, is 1 year's worth of Ovestin is the equivalent to one HRT tablet. And it's just about to be able to buy it over the counter if they can get enough stocks in. So just be mindful that your GP, if you speak to them, may suggest, well, if they're a good GP, they'll suggest you go onto Ovestin. But that may be something to consider, because if the tissue is sore within the vagina or it's dry as it is within the menopause, then it will be that way in the bladder. And if there's wrinkles within the bladder tissue, urine will get in and it will irritate the bladder, and you want to empty the bladder all the time. And a little bit of vaginal estrogen can remove all of that. So treating urgency and urge incontinence, the first thing we'll start is bladder retraining. So we stop going just in case, and we start to introduce delay tactics. Now, it's very common for me to hear my symptoms are terrible at home, but when I'm at work, they're not that bad. And that's because when they're at work, they're distracted, or they know they can't go to the toilet. And one of the things is, it is not a mental or a psychological problem, but it is made a million times worse by patients' anxiety about it. Just like we can all remember being at school when we sat exams, you go to the toilet, you get into the exam and you think, oh, I need to go to the toilet again. And you didn't need to go to the toilet again because you've just been, you physiologically do not need to go. But part of the flight and fight response, part of the release of adrenaline makes you feel like you want to go to the toilet. So if you're anxious about going to the toilet, it's going to be 10 times worse. So we start to introduce those delay tactics, just holding on for a couple of extra minutes, a nice big strong pelvic floor contraction, count backwards from 950 in sevens, anything to get you thinking away from it, because if you can control the urge, most likely it will pass in a couple of minutes if you can delay going to the toilet. So pelvic floor exercises, we employ the pelvic floor inhibitory reflex, which is, we talked at the beginning that if the bladder is contracted, the pelvic floor will be relaxed. So if your pelvic floor is contracted, your bladder will relax. So if your bladder is trying to contract to empty, and you do a really, really strong pelvic floor exercise and you hold it for about 10 to 15 seconds, that will override the bladder and it will make it contract. Make it relax, and you'll stop needing to go to the toilet. So that's one of the tactics we use. And the thing to remember is this is going to take time. Okay, your bladder didn't get to this state overnight, and so it's going to take time, but it's sticking with it. As I said, I remove all caffeine and stimulant drinks from patients' diets, and that I did have a patient once who was 22 and she had the most awful urgency. And then I discovered she was drinking 2 litres of Coke and 9 espressos a day. And when we stopped all of that, amazingly, she hadn't got any bladder problems. So that can be quite an extreme one. And also removing alcohol. Alcohol's different. Alcohol works as a diuretic, and it works to slow down our reaction time. So it actually makes you want to go to the toilet more because you've produced more urine, but the muscles can't work as effectively because they're on a little bit of a go slow. So we'll remove those from patients' diets. So the other options are for urgency is medication. We've talked about topical estrogen, so that's estrogen used within the vagina, and anticholinergics are another medication that we can try. And what they do is they reduce the bladder contracting unless it's full. It's all very clever, and I don't quite understand all the pharmacology, but I do know it works. So we can put patients on anticholinergics. Now, the thing about this is we don't intend to keep patients on them forever. The hope is that we put them on anticholinergics, their bladder will retrain with all the tactics that we've given them and all the support we give them with exercises. And once the bladder has calmed down, we'll give them a few months being calm, and then we'll start to remove the anticholinergics, and hopefully the bad habit has been broken. So that's one of the other methods we use for urgency and urge incontinence. Now, treating stress incontinence, however, primarily comes down to pelvic floor exercises. As I said, they are a special group of muscles. They're working at 30% of their capacity all the time, which means if you give them a huge workout, they'll just fatigue at the end of the day, and you'll find that your body symptoms are worse at the end of the day. So with pelvic floor exercises, the trick is little but often. So I will work with my patients and get them to do, 4 little sets of exercises every day. That's the key to strength training a pelvic floor. We exercise the same contraction every time, but we exercise it 3 different ways to facilitate all of its roles. But it's essentially the same contraction. There is a fantastic app called the NHS Squeezy app that I really encourage women to have on their phones, because pelvic floor exercises are a bit like brushing your teeth. Even when you strengthened your pelvic floor, you need to keep doing it a couple of times a day just to keep it strong, because it is working against gravity all the time. It is having to counterbalance every time you lift something, every time you sneeze, every time you step off a curb. It's having to work against that. So the NHS Squeezy app is £2.99. It's a one-off fee. There's a girls version and a boys version. Please don't get the boys version, because their pelvic floor is a little bit different. It does work and it has its functions, but not quite the same as ours. But it's a really good app, and it's available on Android and iPad, and I would encourage patients to get it. There is a setting for patients to start straight away, and then there's a setting for them to work with professionals if they need to. We can just change things a little bit up more as professionals. So I'm going to get to run through how to do a pelvic floor exercise, because very often patients are told you need to do your pelvic floor exercises, but no one's ever really told how to do a pelvic floor exercise. So the first thing to do is to remember is to sit comfortably, preferably with your knees apart and your feet flat on the floor. If your knees are pointed, it will tighten your calves, which will tighten your thighs, and then your pelvic floor can't relax properly. So just sitting comfortably, the best way to think about it is to try and lift your back passage as if you were trying to stop yourself passing wind. So it's kind of a pulling together and then lifting the skin around your perineum, which is the skin between the vagina and the anus. Try to lift that away from the chair that you're sat on. And as I said before, never try to stop yourself passing urine. That is the action of the pelvic floor, but it is not the way the pelvic floor is supposed to work. So that's how we exercise it. To exercise it for speed, which is really what we need for stress incontinence, because stress incontinence is all about the fact that your muscles aren't fast enough and strong enough to stop the leakage of urine on cough and sneeze. Then you try to contract your pelvic floor muscles as fast as you can, and then you let it go. Now, when I say speed, it's about how quickly can you contract those muscles, not how many can I do in 10 seconds. It's not frequency, it's speed. And what you want to try and do is repeat that 10 times. Now, if you can only get to 4 contractions, then that's where you start. There's no point trying to exercise a muscle that's fatigued. It just won't do anything. So it may be that you start on about 5 quick contractions. So it's all about the speed. I'm sitting here doing them now because after 20 years, I can't say pelvic floor without actually my pelvic floor contracting. And if you are strengthening a pelvic floor, you'd need to do that 4 times a day. As I said, once it's normal and that number is 10 and you can repeat that 10 times, then twice a day is more than enough. Oh, we jumped. The other type of pelvic floor is an endurance one, and these are really important to control the pelvic floor inhibitory reflex, to help control urgency, but also to help control pelvic organ prolapse. And so you contract your pelvic floor muscles and you count in seconds to 10. Now 10 seconds is not 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's more like 1,000, 2,000, 3,000. So you try to contract the muscle and hold it again up to 10. If you can hold for 10 seconds, your pelvic floor is strong enough to be able to do what it needs to do. Or if it's not doing what it needs to do, then we would move on to other treatment techniques. But again, you're aiming for 10 contractions held for 10 seconds. If you can do 4 contractions held for 5 seconds, then that's your starting point. And I would say do 4 contractions for 5 seconds, 5 quick contractions, 4 times a day. And that can all be plugged into the Squeezy app. And so if any of these things I've said today ring a bell in your head and you think, actually, yes, that's me. First of all, please note it is not normal. We've got very good at confusing the word common and normal in the UK. Pelvic floor problems are very common. They are not normal. Cancer is very common. It's not normal. So please don't be fobbed off. Most areas in the country, in fact, I don't know an area that hasn't got access to pelvic health physiotherapists. We're a little bit of a weird brand. The rest of the physiotherapy world thinks so, indeed, as well. But we're highly skilled and we do postgraduate training to be able to do this job. So ask your GP, tell them, in fact, don't even ask, just tell them I have pelvic problems and I would like to be referred to a women's health physiotherapist, please. There are a couple of things available for patients to have direct access to. There's a website called the POGP website. That's physiotherapists in obstetrics, gynecology, and pelvic problems, and they have a website called the pogp.co.uk where there are patient accessible information. It can be printed off. It's very easy to read, and you can access that at any time. And for patients for women who want to start working on their pelvic floor or their core as a whole, but perhaps aren't feeling particularly confident about doing Pilates classes. Pilates is excellent, by the way. A really good Pilates class will strengthen your pelvic floor. There's a really good program called the Pelvic Core Exercise Program that is on YouTube, and that's actually done by one of the leading women's health physios in the world. Her name's Kari Bo. She's Norwegian. She looks amazing. We all hate her, but she's amazing. So you can watch that. It's about a 25-minute exercise program available on YouTube that will tone all of that pelvic area in a very safe way, guided by a physio. And that's about it, really. Does anyone have any questions?